Thanks, everybody. Thanks for coming out on this wintry night. I'm going to talk about our work specifically, but I'll talk a little bit also about the vagus nerve, which is something that's used for quite a lot of very interesting therapies. So the work I'm going to talk about is supported by this organisation, DARPA, which is Defence Advanced Research Projects Agency. DARPA is a very interesting organisation because it has a very open remit, and its major remit is to work and finance things that are blue sky, that might have a low chance of success. One of the things that DARPA supported was the development of the internet. And they've had interest in areas of health. It's a collaborative work between the Florey, where I am, and Robin McCallum is, the Bionics Institute, which is an institute that builds instrumentation, where Rob Shepherd is, the University of Melbourne with David Graydon, and Austin Health, because we have to have clinicians involved, and the principal clinician is Bob Jones. Now, the vagus nerve is a mixed nerve. It does lots of things, and it's only in recent years it's been discovered that the vagus nerve can be used as a place to stimulate to treat a number of disorders. And it's quite surprising, the range of things that the vagus nerve does. It's been approved as a site to stimulate to treat epilepsy, because it takes messages to the brain. And over 100,000 people now have implants to stimulate the vagus nerve to treat their epilepsy. It's been approved, and in fact there's a lot of people who have stimulus for cardiac arrhythmia to try and prevent heart attacks. It's been approved for stimulation for depression, although it's early days in using it for depression. There's work for asthma in development. When you'll see the diagram coming up, you'll see it goes to all these places. In weight control, in headache, which is experimental, in stroke and heart failure, and in inflammatory bowel disease. And this is under active investigation by 2 or 3 groups around the world, including our group here in Melbourne. So the vagus is a very interesting nerve. It comes from the brain, it takes signals from the brain to the periphery, and it takes signals from organs to the brain. Important in its pathways are nerves that control the heart. They control the rate of beating of the heart, and they also control its regularity, the rhythm of the heart. So you can see that the vagus might be a target for dealing with arrhythmias, as it is. It provides pathways to the lung, and it changes the diameter of the airways, and that's why it's a target for dealing with constriction of the airways, such as in asthma. It also goes to stomach, and the pathways from the stomach are the pathways that control appetite, and so that's why it's been targeted for appetite control. And to the liver, other parts of the intestine, the kidney and the spleen. The spleen's important because it's involved in inflammatory reactions. So, and another branch that's important is it goes to the larynx, it goes to the upper part of the airways. And one of the side effects of stimulating the vagus in the neck, stimulating it up here, can be hoarseness, because it stimulates these nerves that go and constrict the larynx, tense the muscles in the larynx. So, but it goes in the other direction too. So here's a different diagram. The vagus is taking information from the gastrointestinal tract and the other organs into the brain. And that includes areas of the brain that are involved in emotion, and the vagus stimulation affects emotion, in movement in the thalamus, in control of visceral function, for example, in the locus ceruleus, which is this region here, and in this part of the cortex, the cingulate gyrus. So the vagus is a two-way tract, and what many people like us are trying to work out, what is the ideal way to stimulate the vagus so that we activate a particular pathway that we're interested in. So our interest is in the control of inflammation, which the vagus does. So our target is inflammatory bowel disease. Inflammatory bowel disease has two types. One is Crohn's disease, which is a disease mostly of the small intestine, and the other is ulcerative colitis, which is a disease, as it suggests, of the colon. This is what the bowel looks like when it has one of these inflammatory diseases. All these bright pink, rough-looking areas are areas where there is inflammation and there is tissue damage and there is a possibility of fluid moving into the bowel and also into the body from the bowel. If we look around the world, then the parts marked in this dark reddish colour are where there are high incidence of inflammatory bowel disease. The white areas where we don't have any good data. Australia, so this is high. Australia's in the sort of medium group of countries, there's medium incidence of this disorder. New Zealand's a high country, and so is Britain, France, and Scandinavia, including Iceland, which I guess is almost a part of Scandinavia. So it is common in some countries. So in the United States, about 100 to 450 per 100,000. That means more than one person in 1,000. More than one person in 1,000 is a lot. So in a city like Melbourne, that means there's 5,000 or 6,000 people with inflammatory bowel disease. The incidence is higher in combat veterans. That's why the American military is interested in it, because combat veterans get these inflammatory bowel diseases usually in their combat years, which are generally in their 20s or early 30s. So by the time they're maybe in their early 30s, they may have these disorders at twice or more the national average. And then it's the responsibility, of course, of the American government through Veterans Affairs to look after these combat veterans for the rest of their lives. And this is not a disease that kills you, but it's a disease that makes you very sick. And so they will have to look after these combat veterans from the time they're 25 or 30 to when they're 70, 80 or 90. So that's why, of course, they're interested in it. Now, there are treatments for inflammatory bowel diseases. The problem with them is they don't work very well. They don't work in all people. And over time, they stop working. So, and the other thing is they are quite expensive. It can cost many thousands of dollars a year to treat somebody medically who has inflammatory bowel disease. If it gets really bad, then part of the bowel has to be removed. That often doesn't solve the problem because the inflammatory disease pops up somewhere else in the bowel, and some people have had, unfortunately, 3 or 4 or 5 surgeries to try to deal with it. Okay, so this is the reason why we think we can use the vagus, because we know that if the vagus nerves are cut, then any inflammation in the bowel gets worse. And that's been done experimentally. There are also people who have their vagus nerve interrupted for one reason or another. So it's consistent that if you remove the connection between the brain and the intestine that goes through the vagus, inflammation in the intestine gets worse. The inflammation causes the gut to be leaky. You saw in that horrible picture how red and inflamed the inside of the intestine was. That means that body fluids leak into the intestine, but more importantly, intestinal fluids get into the bloodstream. So if intestinal fluids, which contain bacteria, you probably know there's a lot of bacteria in the gut, get into the bloodstream, that causes septicemia and causes liver damage. So this leakiness is an important aspect of inflammatory diseases of the bowel. And vagal nerve stimulation in the neck affects various targets, including the heart and lungs. So if you stimulate the vagus in the neck, you slow the heart and you affect the upper airways and cause hoarseness or sometimes a bit difficulty in breathing. So what we're doing is a new way. We're looking at stimulating the vagus in the abdomen because we're interested in abdominal organs. So we're trying to devise a way where we can stimulate the vagus below the heart so that we don't get the side effects that you sometimes get from stimulating the vagus in the neck. And what we're trying to do is activate what's called an anti-inflammatory reflex. When the intestine is inflamed, or other organs in the abdomen as well, when they're inflamed, they send signals up the vagus nerve into the brain. And some of the inflammatory agents get into the veins and go to the liver, and they stimulate liver branches of the vagus nerve. So this goes into the central nervous system, and then it provides an output, which is anti-inflammatory. And part of that output goes back down the vagus, and some of it goes in other pathways, which are called sympathetic pathways, which come from the spinal cord to the gastrointestinal tract. So we've been trying to work out how these circuits work. I'm not going to talk in much detail about that, and whether stimulation here will actually have an effect to depress inflammation. We have designed a system and we've built it, and what we've done is used a transmitter and receiver which we can direct from outside the body. So we use a thing rather like a mobile phone, and we can direct how this controls the stimulation, and this is fully embedded in the body, and we put it in the same place that a cardiac pacemaker is placed, near the clavicle, and we know that's a safe place. People have had cardiac pacemaker controlling units in that position for 30 or 40 years, and so we could do it there. And then we bring a lead down under the skin. It comes down under the skin, and it then goes below the rib cage and then connects with the vagus nerve. So we can use a technology and a surgical approach that is close to one that's already proven to be valuable and safe in humans. We have two places we can stimulate, and this is where you need to do experimental work and provide some proof that the system will work in animals, which is what we're doing. We have possibility of stimulating the whole vagus, but of course if we stimulate the whole vagus, we stimulate vagus to various organs, or stimulating the branch that goes to the liver. And the reason to stimulate that branch, as I showed you a few slides ago, is that signals of inflammation go from the gut to the liver and then up the nerves from the liver to the brain. So that's our rationale, that's what we're trying to do in this work. So to do this, we have to design and prove that they work, a suitable stimulus, and we've designed a type of electrode, which is shown here schematically. Each of these has two little pieces of metal. These are platinum iridium metal, which has little bad interaction with tissue. And so that's a drawing. This is an actual photograph. So the electrodes are little pairs like that. And that's the lead that comes in. And this is a photograph of the electrodes in a sheep. So here's the nerve in the sheep, and you can see here the electrode and the electrode and the electrode around it. So we have to design an electrode that goes close to the nerve and can be placed there surgically easily. So these electrodes are like a little opening clip. They can be held open and then claps closed, so the surgeon can actually put these electrodes in through a small hole. This is laparoscopic surgery. So a small hole is made and probes go in, and the electrodes sort of are clicked around the nerve and placed on it. And we have in the electrode set 3 pairs. So we can use pairs for stimulation, but we can also use a pair for recording. So when you stimulate the nerve, you get action potentials, electrical signals go along the nerve, and we record those signals. This allows us to know that the electrodes are effectively stimulating the nerves. And this is important because you've got to know that you're doing what you expect you do. And this is an example from a sheep that's been implanted. And these are the action potentials, the electrical signals that we've evoked. So why do we use sheep? If we're going to put into a human being a implant that they're going to live with for a long time, maybe 10 years or 20 years, then we have to know that something we design for a human, which is human size, works. And so we have to use a human-sized animal, and a sheep is a very convenient animal to use. So we've implanted a number of sheep. The sheep don't seem to mind. They go about their usual daily lives, eating and doing sheepy things. And we can, in a freely moving sheep, we can detect a signal, electrical signal, and we can see what's going on, and we can see, is it safe? Does it cause any damage to the animal? Does it disturb the animal's behaviour? And does it last? I mean, do these electrodes survive over many, many months? So that's the reason why we're doing these experiments in a sheep. This thing, TNBS, is an irritant chemical, and it's an irritant chemical that causes inflammation that is very much like the inflammation in human disease. It has the same characteristics when you measure the inflammation. If we have a sham, which means we inject a salt solution that has no effect, we don't see very much. If we inject this material, we see an inflammation, which is measured here in different ways. If we cut the vagus nerve, so we have no vagal signal, then this inflammation is bigger. It's twice as big, with 3 different ways of measuring it, one of which is permeability or leakiness. So the gut becomes more leaky, it becomes inflamed, and it becomes leaky and inflamed more if you don't have a vagus. Because if you don't have a vagus, you remove that feedback circuit, that anti-inflammatory reflex circuitry. So this is one of the pieces of evidence that pushed us in the direction of stimulating the vagus. Because if you remove its activity, you make things worse. So we figure if you increase its activity, you should make things better. And that's exactly what happens. Now, these are pictures that will take a few moments to understand. This is the normal lining of the intestine. The lining of the intestine has these long fingers, and these fingers wave in the lumen of the intestine, inside the intestine, so they have a big surface area and they take up the nutrients. They're called villi. If now you use this inflammatory agent, you can see they've all collapsed. So now you can just see the basis of them. You just see up to about there because the villi have collapsed. The ends are broken quite often. So you've lost the absorptive surface of the gastrointestinal tract. And that's what happens in inflammatory disease. So people don't thrive, they don't absorb nutrients properly. It also happens in other gastrointestinal diseases like celiac disease, where these villi are lost. So look what happens if we stimulate the vagus. And in these experiments, we've stimulated the vagus every day for a period of time for a week. Everything else is exactly the same. And what you see is these absorptive fingers in the gastrointestinal tract grow back or recover. So we can reverse the damage that is causing, we presume, the leakiness, but it's certainly causing the poor utilisation of nutrients by in this case, an animal, with vagal stimulation. And this just shows at higher power. This is the end of a healthy villus, the absorptive surface. This is the end taken from there when it's damaged by an inflammatory stimulus, and this is the recovery of the villus when you stimulate the vagus nerve. So this is what's called a proof of principle experiment. It tells us that in principle this ought to work. I mean, of course, it's an artificial situation because it's an animal, it's not a human with disease. And that damage can be quantified, and this is a quantification of the damage. So it's called a histological score when we do this. So this is normal intestine, very low score. This is after the inflammatory stimulus, a high score. It can go up to 100, that's the maximum you can get. And this is after you've stimulated the vagus nerve. And you can see it hasn't quite come back to normal, but it's come back a long way. So it looks like this is a viable way to treat this horrible disease of inflammatory bowel. You can also look at the proteins that cause inflammation or that are released during inflammation. These are called inflammatory cytokines or inflammatory mediators. And again, we see a control. There's always some, intestine's very interesting. It's always a little bit inflamed. It's always a little bit inflamed because you're always taking in food that has some degree of contamination. You know, you're taking in some bacteria, you're taking in some dirt or toxins or whatever. So the intestine, the natural state of the intestine is to be a little bit inflamed. And that little bit of inflammation you can reduce by vagal nerve stimulation. So that tells us the vagus is quite capable of acting, even in a normal situation, to hold things back. And here we have used this inflammatory agent to cause the release of the proteins are released during inflammation, and again the stimulation pulls this back. So we see a reduction in the damage, and we see a reduction in the agencies that react to the inflammation, the inflammatory mediators. Okay, and you can measure what's going on by a disease index. The behaviour of animals changes, and of humans, of course, when they have inflammatory disease. Their stool changes, their temperature changes, and so the activity of disease in people, you temperature goes up, you become more lethargic, your skin colour sometimes changes, and we can look at that in animals and measure that. And again, the stimulation reduces the disease index over time. So whether we look at the organ itself or the whole animal, we get the same answer, that there is a suppression of the disease by the vagal nerve stimulation. We have a colleague in France, and that colleague, his name is Bruno Banaz, has done the first trial in humans. This is a bit complicated, but what he's done is a pre-treatment period and then a period of treatment, and looked at after 6 months. And the disease activity for Crohn's disease is reduced. You can see the reduction there. This is patient 1, that's a reduction, and this is another patient, the reduction. This is another patient, another. So you can see the degree of effect varies between people, but it's a consistent effect. There's consistently a reduction in the intensity of the disease with vagal nerve stimulation. Now, he did this in the neck, and in these people, they have the side effects that come from stimulating the vagus in the neck. We're stimulating within the abdominal cavity, so we don't have those side effects. But we work together, so I'm not criticising him too much. So how can we make a good measure of whether this is effective? Now, I told you that the gut becomes leaky when it's inflamed, and this is normally assessed by an endoscope. So a tube is put up into the bowel, and the physician looks at it and says it's more or less inflamed and makes a subjective view, or takes a biopsy. That uses an apparatus to take a small bite out of the lining of the intestine, and that goes off to the laboratory to be examined. So looking is okay, but it's difficult to look and judge and make a objective and quantitative view of things, and a biopsy goes off to the path lab and comes back next week. So we thought that the leakiness that occurs could possibly be measured, and that might be a better way of determining the degree of disease. And we've invented a method to do that, to measure the electrical impedance, because it becomes leaky to molecules, it also becomes leaky to salts. And therefore, and salts are electrolytes, they carry currents, and we can measure then the resistance. So this is the thing we've invented. It's pretty simple. It's a flexible line with wires inside it. It goes through a transition into the wall of the intestine. Inside the wall of the intestine are a number of electrodes, and there's another electrode at the skin. Skin electrodes are very common, of course. They're used for looking at the electrocardiogram. Many of you may have had these electrodes put on your surface to measure, so you can measure across the skin. So we have one electrode like a conventional electrode on the skin, and another one in the bowel wall. These are quite small. This is a centimetre here, so it's very thin. This is a transition, and this is a bit in the gut wall, which is about 0.5 millimetre in diameter. So it doesn't actually interfere with digestion or anything else. And when we use, in this experiment, it's a very short-term experiment. This is a sheep. And so here's the measures of resistance with different electrodes. Here, the inflammatory irritant is put in, and you can see that the resistance drops. So we can measure that, and you can see it's quite easy to see, and we can follow that. I'm not showing you any data on that, but we've followed that over many weeks. So we can understand what is actually happening. Now there's an electrical signal we're getting, so we can use that for feedback. We can use that signal to tell us how bad the inflammation is. Knowing how bad the inflammation is, we can adjust the stimulus that we're giving to the vagus to try and reduce the inflammation. So we have a feedback system, a monitoring system that allows us to determine just how hard we should stimulate the vagus nerve. So these are the next steps. We've got to this point. We've got something that works in rats, it works in sheep. We've got a design that's suitable to going into humans. We've got a surgical approach which is rational and fits with what's been done before. So we now are in the stage of manufacturing these devices. So this, if it's going to go into a person, has to be made in ultra clean circumstances. Anything you implant into a person must have bring no bacteria or fungi or viruses or anything else with it. So we're in that process of setting that up. And some of this manufacture has to be done robotically, not untouched by human hands. We're going to determine the safety and effectiveness over a longer period of time in animals. We've done it over a month or so. And then the plan is to implant these devices into Crohn's disease patients and test the effectiveness. And this is going to be done at the Austin Hospital with our clinical collaborators. This takes big teams. So we have a team doing the functional studies that I've just talked about, led by Robin McCullen, who's here at the Florey Institute. Team doing a modelling and mathematical analysis just to see how everything fits, and that's led by David Graydon, who's in the University of Melbourne. The large animal work is done by myself mostly, and by Sophie Payne, who's from the Bionics Institute. And the device design and testing team is also at the Bionics Institute. The clinical people are Bob Jones, who's a surgeon, and Peter De Cruz and Adam Testro, who are leading physicians who run the Inflammatory Bowel Disease clinic at the Austin Hospital. And the program management, we have a program manager to try and put all this together, and myself working in that. And our support comes from DARPA, and also the institutes involved, obviously, provide facilities and support. And we couldn't do without the support of the Florey Institute and the other organisations. Without the infrastructure and the equipment and so on, and the facilities such as the animal surgeries here, we couldn't possibly do this work. So that's where we are, and hopefully in 2 years' time we'll have done the clinical trials and be able to tell you what the outcomes are. So thank you very much for coming. Thanks for listening.